friends, welcome to our first installment of Mystery Disease in a Box. Thank you so much to our sponsor, MysteryDiseaseInABox.com, for sending us this amazing box full of information on this week's mystery disease.
There is so much great information, there is no way we can go everything in one part. So be sure to give us a like, follow, post your guesses in the comments, and be sure to stick around for part 2, where we will reveal the disease, cover treatment options, the effect on the individual, and effect on dental hygiene treatment. Are you ready to get started?
Let's do it. All right, look at this handsome man. All right there for you guys.
Looks like we're going to have a bit of history lesson to get started. This disease may have first been described by David McBride in 1777. In 1943, Seva discovered that the lesions present in this disease were caused by ankylosis, also known as the loss of cell adhesion. In 1964, two medical students, Bettner and Jordan, found that the blood serum of patients with these lesions have an IgG autoantibody that attack the cell surface of keratinocytes. The discovery of these autoantibodies led to the important understanding that this is an IgG-mediated autoimmune disease by 1991. It was found that the autoantibodies in this disease are directed against molecules and cell adhesion structures.
Okay, so it looks like we're dealing with an autoimmune disorder. Let's see what else we have in here. Ooh, okay. So it looks like we're getting into the histology of the disease. So, like we mentioned earlier, the lesions of the disease are caused by the loss of cell-to-cell adhesion. Desmosomes are a type of cell junction which hold tissues together and keep it from breaking apart. These kind of look like the little blue snaps in the diagram. Patients with this disease produce autoantibodies that attack desmoglin 3, a critical protein for desmosomal adhesion. With compromised desmosomes, there is a loss of adhesion between keratinocytes in the deepest layer of the epidermis, the basal layer. The autoimmune defects affect both the skin and the mucous membranes that can cause blisters and sores, such as in the mouth or on the genitals. This disease begins around 50 to 60 years of age typically, and it affects both sexes equally. The etiology of this condition is unknown, but there is a genetic predisposition. Several studies have linked the disease with human leukocyte antigen, or HLA, class 2 alleles.
This is getting interesting. Let's keep going.
Okay, oh, look what we have here.
Oh wow, that looks so painful.
Yes. Oh, looking at the redness and being in the mouth where things can just get extra sensitive is enough for me.
I totally agree.
Yeah, it looks bad.
Yes. All right, so these erythematous lesions are caused by autoantibodies destroying the desmosomes and hemisomes, forming bullae that can easily rupture. 80% of the cases of this disease begin on the oral mucosa. I'm sure that it is painful, and not being able to eat may lead to poor nutrition status, which is not good. I wonder if it can spread or show up in the conjunctiva, nasal mucosa, larynx, pharynx, esophagus.
You know, it really can. Let's see if there's any other symptoms that happen outside of the mouth.
Ooh, yeah.
Oh, this might be a trigger image for y'all. It's a pretty graphic photo.
75% of patients with oral lesions also end up with cutaneous lesions. The cutaneous lesions often appear on the trunk, face, groin, scalp, and axillary areas. Some patients with this disease have presented to the emergency room and have been sent immediately to the burn unit. While these patients are not burned, the patients and medical staff there are the best to care for the amount of tissue destruction seen with this disease. Similar to how this box, the design, print.
This box is rather diseased looking. All right, so we're wrapping up part 1. Do you know what this mystery disease is yet? Be sure to drop your guesses in the comments. Come back for part 2 and we'll reveal the disease, discuss treatment options, how the individual is affected, and how we, as soon-to-be dental hygienists, will work with patients living with this condition. Stay tuned.
Welcome back to part 2. This is our first installment of Mystery Disease in a Box. Are you ready for the big reveal?
I'm ready. Pemphigus vulgaris.
Pemphigus vulgaris.
All right, so did you get it right? Pemphigus vulgaris is most common type of pemphigus. Pemphigus is a group of rare skin autoimmune disorders that cause blisters and sores on the skin or mucous membranes, such as in the mouth or on the genitals. Vulgaris is Latin for common, and when used in the name of a disease, it indicates the most common form of the disease. It is characterized by intraepithelial vesicle formation that results from the breakdown of cellular adhesion between epithelial cells. There are 3 other forms of the disease: Pemphigus vegetans, Pemphigus foliaceus, and Pemphigus erythematus. These are much rarer conditions, but the overall are characterized by acanthosis, or the epithelial breakdown of cellular adhesion within the prickle of the cell layer of the epithelium.
Let's see what else we can learn about Pemphigus vulgaris.
Oh gosh, let's see what we have. Okay, so this is important. How is this disease treated?
So now we know the disease and how it occurs. But how the heck is this treated? The first-line treatment of Pemphigus vulgaris is immune suppression via corticosteroids. This slows down the body's antibodies, giving the body time to heal existing lesions and prevent new lesions from forming. It can take several weeks to achieve a response. Tapering down the dose can be initiated when symptoms are improved. But if reappearance of more or 3 lesions occur, then dosing should be increased again to induce remission. If corticosteroids alone can't treat the patient's condition, azathioprine or other immune suppressant infusions may be added to their treatment. Azathioprine should be discontinued if no improvements are seen within 3 months. Dosing should be adjusted based on renal function, and the goal of the treatment is to quickly, effectively treat the disease and then gradually reduce the use of steroids to avoid reoccurrence.
Wow, we've really learned a lot today. I think we have a couple more things in here. All right, so it looks like we're looking at the psychological implications of Pemphigus vulgaris. Besides the pain and discomfort someone can have, I can only imagine the psychological issues that also arise. While living through the process of finding their diagnosis, many patients living with Pemphigus vulgaris experience what's called medical trauma, which is defined as a set of psychological and physiological responses to pain, injury, serious illness, medical procedures, and frightening treatment experiences. Patients experience their doctors working hard to address the physical symptoms of the disease, but the patient is left to their own devices to address their mental health. And mental health is just as important as physical health when dealing with a rare and debilitating disease. Patients living with Pemphigus vulgaris are encouraged to seek out help from a licensed mental health provider. Along with finding a provider that works well with the patient, it's beneficial for the patient to explore the different types of therapy, such as cognitive behavioral therapy, interpersonal therapy, art therapy, and music therapy. Everyone, all of us included, can benefit from therapy, but it's especially important if they're living with such a complex disease. Looks like we only have one more thing in the box.
Oh look, this one pertains how we can help those living with Pemphigus vulgaris when we are working in the real world. To help a patient with an oral mucosal disease, there are ways to minimize symptoms and treat your patient's oral care needs. Patients should come in for their cleaning and exams every 2 to 3 months. This is especially important if they are periodontally involved. The hygienist should use gentle hand scaling to avoid disruption to the tissue. Use the ultrasonic scaler only if absolutely necessary. For polishing teeth, it would be beneficial to use a mild paste similar to what is used at home so the patient does not have a reaction to it. Gritty or coarse polishing paste should be avoided because it will likely cause irritation to the tissue above and below the gingival margin. Any tissue that does not respond to treatment may need further evaluation and a possible biopsy. It is also good to know and question your patient if there are any triggers possibly to the irritation they might have in their mouth. Keep in mind it can be caused by certain foods, beverages, and oral care products. As always, document what you see in their mouth, take photos, and reevaluate their conditions every visit. Encourage your patients to also be aware of their oral conditions and have them notify their providers of any changes.
All really great information. A huge part of our job is patient education. It is important that we give the patient the tools and knowledge they need to take care of their mouths at home. Recommend a toothpaste without harsh flavoring agents such as Xerostome or Biotine. Sodium lauryl sulfate can also be an irritant and should be avoided in their toothpaste. Children's toothpaste is a good option because they have limited ingredients and often have less flavoring agents. Dry mouth is a common side effect of pemphigus vulgaris and its treatment, so the use of mild sugar-free chewing gum or lozenges should be recommended. When the patient has active, sensitive lesions, a specific super soft bristled toothbrush is recommended. Alcohol-free mouth rinses, floss, and dental brushes should be used to help control biofilm accumulation and keep the oral cavity as healthy as possible.
That's all the time we have. We hope you enjoyed this installment of Mystery Box in a Box and learned a lot.
Thanks!